Today's speakers all come from CMQCC, and they are leaders across our organization and specifically on the Low-Dose Aspirin pilot campaign project. I will just let you look at their titles and credentials here. And then as they each come on, we'll just ask that they do a short introduction and explain their role in this pilot project. So I think that is that's it for me. And I want to turn it over to Dr. Amanda Williams.
All righty, well, let's pull up the next slide. Thank you so much for that kind introduction to our work today, Gina. And thank you to all of you who are tuning in. I'm Dr. Amanda Williams. I am the Clinical Innovations Advisor at CMQCC, and it is my privilege to be the physician lead in this low-dose aspirin project. As some of you have heard me say before, I am personally a preeclampsia survivor from the before times, from the before aspirin times, and do actually mark those days with preeclampsia with severe features with my baby in the NICU as being some of the hardest of my lives. So I come to this with a witness as a OBGYN of 20 years, as a physician leader, and also as a Black mother in America. So when we think about context and a little bit of level setting and introduction, because everyone is in a different place in terms of their knowledge with low-dose aspirin and preeclampsia, we know that hypertensive disorders complicate many of the pregnancies, and this is part of what we do every single day in our care of pregnant patients. And preeclampsia does impact 3 to 5% of pregnancies yearly, causing severe morbidity and mortality to both the parent and the child. Prophylactic low-dose aspirin, and in the United States, we use 81 milligrams. In other countries and in other settings, there is some data for other doses, and that is an active area of research and investigation, but the current recommendations are for the 81 milligram low-dose aspirin dosing to prevent preeclampsia, preterm birth, perinatal death, and truly this is an opportunity to do primary prevention. So the same way that patients are taking their prenatal vitamin every morning, maybe with some fish oil, maybe with the iron, the low-dose aspirin should be right there on the counter next to it. We also need to make sure that we're talking about the consequences of preeclampsia in the ongoing life of our patients, because it does increase risk for hypertension and cardiovascular disease later in the patient's life. And so when we hand off to our colleagues in internal medicine, family medicine, et cetera, it is important that that history is part of their story. In terms of screening and starting low-dose aspirin for our pregnant patients, the goal is to start near the beginning of pregnancy, and we aim for about 12 weeks, but everyone should be screened. So even though there isn't quite enough data, and I'll talk about this later, to recommend for everyone within just exclusion criteria, everybody should have screening in the beginning of their pregnancy. And this is not just a CMQCC recommendation. This is from the U.S. Preventative Services Task Force, Society of Maternal Fetal Medicine, American College of OBGYN, are all in concordance that we recommend low-dose aspirin for anyone who has any of the high-risk factors or more than one moderate risk factor, and can consider for just one moderate risk factor alone. Next slide. So to double click on that risk factor screening, when do we want to do it? We want to do it at the first or second prenatal visit, aiming for about 12 weeks of pregnancy, but there is benefit up to 28 weeks. So oftentimes I'll hear from my MFM colleagues, well, we didn't see them until later in pregnancy, but there is still benefit. So we should still be making sure that patients are being screened and started started appropriately. Whether the pregnancy is high risk or low risk, we want to be doing this screening. Next, and particularly, we want to make sure that we are engaging nurse practitioners, midwives. Sometimes in practices, a patient will start with one provider and then that risk stratification will happen and then move to another provider, even if the provider is taking care of primarily low risk patients, because those moderate risk factors are demographic. They also should be screened by those low risk providers. Next slide. So this is super busy, but it is an opportunity for us to look at the list. So on the left-hand side, as you're facing it, looking at the high risk factors, these are the ones where there really is no argument. These are significant clinical conditions that the patient is coming to the pregnancy with and need to be followed by a moderate or high risk provider in many instances. If a patient has any of these conditions, preeclampsia or prior pregnancy, chronic hypertension, twins, triplets, pregestational diabetes, any kind of renal dysfunction or autoimmune disease, those patients should certainly be on low-dose aspirin. The more complex conversations and where there is a bit of opinion integrated into this recommendation is the moderate risk factors. So the agreement is if you have more than one. So if you have more than nulliparity, obesity, first degree relative with preeclampsia, Black race, lower income, and we're going to dive into those more, or prior poor outcomes, age over 35, or conception through IVF. If you have more than one of those, 2, 3 of those, etc., then low-dose aspirin is recommended. There is also, in particular, if we could go back to that slide, there is a recommendation for Black race and lower income alone to be a recommendation for starting on low-dose aspirin. And we know that there's nothing inherent about being from a lower income or inherent about something wrong with Black bodies. This is about toxic stress. This is about exposure to systemic racism. And that, especially given how safe low-dose aspirin is certainly reason alone to start patient on low-dose aspirin. And these various societies say that that can be considered, especially for those particular moderate risk factors. Next slide. So when we are having these discussions with patients, we absolutely want to be compassionate. We want to think about our responsibility that patients feel empowered, that they feel well informed, and that they are well equipped to make the best decision for themselves and for their baby. We want to make sure that we are explaining well what's going on with patients. We don't want to say, oh, you're a Black woman on Medi-Cal, you should be on. You know, we need to have conversations. We need to help patients identify that this is an opportunity for prevention and where these recommendations are coming from. Next. And then we want to really make sure we dive into these risk factors, that we are giving patients opportunities to ask questions and to verbalize any concerns that they might have about the recommendation. Now, this seems all, like most counseling and prenatal care seems all well and good, but then you look at that clock and you have a 20-minute appointment and you have to get all of this in. You got to see, are they cramping? Are they bleeding? You got to see what kind of genetic screening they want to do. See, even if they want to continue the pregnancy, there's so much counseling and time required for good compassionate care in the beginning of pregnancy. And so that's why we're working so hard and are deeply grateful for the support from the March of Dimes to do this work, to develop tools to make this as easy as possible for our providers across the state. Next slide. So let's talk a little bit more about being African American or Black as a risk factor. Our country is not comfortable with discussions around race and racism. And we know that it's the exposure to systemic racism that is the risk factor. But being able to have that conversation without having discomfort, without feeling like, oh my God, is someone going to call me a racist because I'm bringing this up? That's really tough. And so we would certainly encourage you to even practice. And we are developing videos to model some of these conversations as well. We live in a country where there are environmental, social, and historical inequities that have shaped these health exposures, access to health care, unequal distribution of resources. There's not a genetic predisposition. There is nothing inherently wrong with Black patients, but the exposure of systemic racism is something that impacts Black bodies. So we want to make sure that we are acknowledging racism as the risk factor, not race. So again, anytime you're making a chart, anytime you are segmenting your data, anytime you are counseling a patient about Black race as a risk factor, know that that is kind of lazy shorthand. We all do it, we all use it because it takes up fewer characters, but what that really means is exposure to systemic racism. So it is the toxic stress that is impacting our patients and the downstream consequences that come from it. So another area that's really difficult for patients to talk about is obesity. And I'm going to turn it over to my colleague, Melinda Kent, to talk about that difficult conversation a bit more. And Melinda, you are on mute. I see your mouth moving, but I don't hear volume.
Can you guys hear me now?
Yes, now we can hear you.
Okay, wonderful. Thank you so much, Dr. Williams. Thank you so much. So yes, my name is Melinda. I've been the clinical lead on the low-dose aspirin for prevention of preeclampsia project since May, working closely with Dr. Duplessis, who you guys are going to meet in a few minutes. And I'm going to go ahead and get started about speaking with patients respectfully about the obesity risk factor right now. So having a pre-pregnancy BMI greater than 30 puts patients in the obesity category for pre-pregnancy BMI. And we're going to talk for a second about what these categories are. So as you can see, we have 3 of the 4 categories on here. Healthy weight puts the patient in the category of 18.5 to 24.9. And that would be the optimum target rate to start a pregnancy in, or really for any of us to live our life in. Overweight is the category of 25.0 to 29.9, and obesity is categorized, like I said, at 30.0 and above. About 50% of our pregnancies in the US actually are conceived in the categories of overweight and obese, and that actually automatically increases risk in the pregnancy. Gestational hypertension and preeclampsia have also been proven to increase the risk for both patients and their offspring to the development of cardiovascular disease and diabetes later in life. And that can cause long-term morbidity, and there are many prevention opportunities which exist, and low-dose aspirin is one of them. However, speaking with that, about that with our patients can be sensitive and it can be difficult. And some of us aren't really sure how to speak with our patients about that in a way that can be truly constructive and sensitive and can really help our patients without our patients getting defensive and have their feelings hurt. So that's something that we're here to talk about. So the systemic racism factor is not biological. However, the obesity risk factor is. So like Dr. Williams was explaining, the systemic racism risk factor has to do with a lot of structural issues that we have in our society and the way health care itself has been structured and built. But the obesity risk factor can have genetic factors, it can have biological factors. So when we talk with our patients, it's really important that we talk about healthcare, and we talk about pregnancy planning, nutrition, physical activity. And when we talk about beginning a pregnancy with a healthy weight with patients and how that helps provide optimum environment for a pregnancy development, a lot of people don't know that. They might know it at a low level. If you just mention it, they might say, oh yeah, that makes sense, but they don't think about it when they're planning their pregnancies. And so if we talk about it with patients who are in even the overweight category, maybe they're at a 27 or 28, they may not know that if they bring it down, their BMI down to a 25 or a 24, that they're actually improving the pregnancy health as well. And so encouraging that health is something that we can do to help prevent the preeclampsia risk, help prevent diabetes risk, and really be educating our patients in ways that are supportive. So obtaining and maintaining healthy weight could also be critical for both the patient and their fetus. And when we speak with our patients about not only their own health, but the health of their fetus, as we all know, that really for some reason hits home with the patients even more. So it's important that we have these conversations in a sensitive way with our patients. So it's vital for those with a pre-pregnancy BMI of 30 or higher, especially, to be educated about these topics and have proper diet and physical activity support, not just speaking to them about it and definitely not at them about it, but helping support them and encouraging them and providing them tools. So let's talk about the conversation approach. If we stand over somebody and lean against a counter, sit across the room, they're not going to really feel like we're having a conversation with them. We don't like being, as humans, talked at. We like feeling supported, and we like having conversations with. So if we pull up a chair, if we sit and make eye contact and have a discussion with a person, they're much more likely to feel supported and to listen to us, have a conversation with us. We definitely want to have this conversation in a private area. So if you are in a physician's office, if you're on a labor and delivery unit, doing it in a private room and closing the door would be the optimum way to do this. Definitely trying to have some privacy. Having information to show the patient, for example, educating about a BMI, and giving them information that they can take home, or showing them a website that they can go to, having them call that up on their phone, and showing them that it's not arbitrary numbers that you're making up or that are important to you, but that this is, we won't use the name or the word evidence-based to the patient, but showing them that it's evidence-based, showing them that it's proven information that can really have effect on them, their family, their baby, really can hit home with them. So showing them the BMI category, not just telling them, as I have experienced, as I know I have friends and family experience, this is your BMI and this puts you, at risk for a health problem. But actually explaining to them what this means so that when they leave, they feel supported and partnered with. Providing strength, not judgment, being an inspirational, motivational person and a role model in their life to talk with them about this topic, encouraging them to lower their BMI, like I previously said, even a few points, rather than saying you're at 34 and you need to be at 23 to be healthy. That might seem like a goal that is way too large, way too lofty to be achieved. But if you can reach a goal that is achievable, like when we talked about clinical quality improvement, right? We want to reach a goal that is attainable and sustainable. And it's the same for this. So asking a patient, what do you think you can do? What is achievable for you? You know, where do you think you can make a change that is achievable and that you can sustain? And maybe you can partner with them and try to provide some sort of assistance in the way of a resource. Maybe you can, if they have insurance that will support it, provide a nutrition resource for them. There is, as I put on here, a CDC resource online that they can go to that has a nutrition weight tracker for during pregnancy, and these type of resources. I know that none of you can sit side by side with these patients throughout their whole pregnancy and help them, but when they leave the office, when they leave the L&D unit, when they leave the clinic, they at least will have some sort of sustainable resource that they can use. Okay, so factors to consider during preeclampsia patient education. Less than half of patients know the signs of symptoms of preeclampsia. This one blew my mind. This was a study that was taken after patients were educated. So a lot of that comes down to how we educate patients. It comes down to the way we educate them and also when we educate them and making sure that they're understanding what we're educating them about, because sometimes they just aren't taking in the information we're providing them. We have excellent reasons that we're educating them and excellent goals, but maybe it's just not hitting home. And when we ask about specific signs and symptoms, that's really good. Saying, do you have swollen feet or any swelling? Have you had pain right here, and pointing to a specific spot on the body rather than saying, have you had epigastric pain? They may not understand what that is. They might just say no. We know patients that, you know, sometimes just answer questions because they're trying to please us, but actually asking about specific signs and symptoms that they understand rather than saying, do you have any signs and symptoms that you want to report? They might just say no, but they don't really know what to report. So those are some really good factors to consider. Knowledge is power. We can empower our patients by educating them and listening to them. Because sometimes, as Dr. Williams alluded to, we don't have a lot of time with our patients. We have to use that time very, very wisely. So patients, as I just said, historically reported a lack of understanding about their preeclampsia. And this is about their own preeclampsia. These are patients that have had preeclampsia, have suffered through this in the hospital, have gone home with the education, and then they report that they don't understand what just happened to them. So knowing the signs of preeclampsia, the symptoms of preeclampsia, is the first line of defense for early diagnosis and treatment. And we have to remember that patients that have had preeclampsia in the hospital can still have postpartum preeclampsia when they go home. They still need to know the signs and symptoms to report. We need them to understand. Patients that are showing the risk factors in the office, pre-delivery, pre-labor, they also need to know what to report. And a lot of them that are educated still don't quite understand. So the more information we can give in the proper formats and in various formats, very important. And the disease process can progress very rapidly and unpredictably. So we really need to make sure that the patients are understanding, have them repeat back to us their understanding so that anything that isn't understood in the appropriate way, we can then make sure that we re-educate and that they understand that this could be life-saving for them. And also that patients and families are the first responders most of the time. They can be at home, at work, family events, friend events, when signs and symptoms occur. So it's important that they understand what to report and how important it is for them to report these right away. Also, some of us are afraid to scare our patients with how severe preeclampsia truly can be. And while we do need to be very sensitive to that, it is important that they understand, because sometimes we have patients who say, oh, it's Thursday, I have an appointment on Tuesday, I'll wait until then. or it's Saturday, I don't want to bother my doctor, I'll wait till Monday. And we don't want that to happen. We want to make sure that they report these things right away. So it's important that they understand how severe this is and that they do need to report things right away. And remember that education of our patients improves outcomes. And we can empower patients by letting them know that they have the power to impact their own outcomes. And that's really empowering for a patient. We're going to move on to making sure that we educate at the correct knowledge level. We could have a patient sitting in front of us that has a master's degree, a PhD. That doesn't mean that when we're educating them about preeclampsia, that we're going to educate them at that level, because they may not have a master's degree, a PhD in OBGYN, in perinatology, in those areas, right? So we're going to educate everybody at a 4th to 6th grade level. That is what is recommended. So when we're doing written patient education, 4th to 6th grade level, we're going to use simple words, short sentences. We're only going to use evidence-based information. We do not put our personal opinions in there. And we're going to use pictures when we're able to. We may be providing this information to somebody who has gone through elementary school and wasn't able to have the privilege that some of us have had to continue their education. And likewise, we may be providing this to somebody with a PhD in literature. So we need to make sure that we provide this education at the 4th to 6th grade level. Verbal patient education, we can educate to the patient's knowledge level, but keep in mind that a PhD may not be in a biological science or to that level. And assure the patients understand and repeat what you believe they understand. As I alluded to earlier, it's important that we converse with them about what we're educating them about. Don't just speak to them or at them, but converse with them. Ask them to ask us questions. Ask them to repeat back and educate you back so that we know that they are understanding that. And if you do provide instructions on how to do something, for example, take a home blood pressure, have the patient, or if their family member is the one doing it, have them show back what you just showed them to assure that they do understand. Moving on to resources. I spoke about providing sustainable resources. There's a couple more resources on here that you can provide to your patients that have great patient education. Besides the patient education that Dr. Duplessis is going to share from our LDA project, there's a March of Dimes preeclampsia page for patients, and there's also a preeclampsia foundation, preeclampsia.org, that has signs and symptoms that's very well produced for patients as well. So I hope that you guys will use those for your patients too. Those are free of charge and they're published online, and you can show those for your patients too. And here's a patient story that we're going to share with you guys. It's only 1 minute long. If the volume is low, please turn your volume up. We have it as loud as we could get it on here.
He's the one who noticed his mom's face was swollen. They're the ones she confided in about her change in vision and headache that wouldn't go away. He's the one who really listened when she said that something just didn't feel right. When she had chest pains a few weeks after delivery, she's the one who insisted on admitting her to the hospital. Too many women die from pregnancy-related complications each year in the U.S. Deaths can occur during and up to a year after pregnancy. It doesn't have to be that way. Most deaths are preventable. Know the warning signs. Hear her concerns. You can help save her life. Learn more at cdc.gov/hearher.
So that was a wonderful video that was created by the CDC, and it's the Hear Her campaign. And I highly encourage any of you who are not aware of the Hear Her campaign to go to their site and to view some of those videos. So I'm going to pass it back to Dr. Williams and we are going to go over some closing statements, and then we are going to move on to the rest of our wonderful speakers. Thank you, guys.
You guys have seen our mission statement. And at CMQCC, we've done a really good job in terms of decreasing the likelihood of preventable morbidity and mortality. And all of you have been part of that work. And indeed, in terms of hypertension, the likelihood of death from hypertensive disorders in the state of California has markedly gone down in the last 2-year interval that was analyzed. But our opportunities around shrinking racial disparities really is what's in front of us right now. And that is part of the reason that we're creating tools, including scripts, educational materials, and videos to really keep this data-driven quality improvement going. But truly, we have to listen. And the more different a patient is to us, we have to listen even harder. Because all of this screening, all of this education doesn't really matter if we don't actually hear it and do something with the information that we're receiving. So let me turn it all over to my colleagues so that you can learn more about the tools that we've developed and how we are using the data to support the quality improvement work that you guys are doing.
All right. Well, thank you, Dr. Williams, and thank you, Melinda. My name is Lindsay Duplessis. I am the Community Engagement Lead at CMQCC, and I'm also the project lead for the Low-Dose Aspirin project. So I'm just going to give you a brief background about the project. So we have been engaging with California. We have about 5 pilot hospital sites that we are working with and their clinics. We're also working with community-based organizations surrounding the pilot hospital sites. And we're also including patients with lived experience. So really uplifting and empowering patients here. And it's really cool because we're kind of bringing together hospital, clinic, and community, which is very needed in many, if not all, interventions. So the Let's Do Aspirin campaign, the 5 pilot hospital sites we're working with, we have Loma Linda University Children's Hospital, and they have 3 clinics. Riverside University Health System Medical Center with 7 clinics. UC San Diego with 3 clinics. Scripps Chula Vista with 3 clinics. And then lastly, Mercy San Juan up in Sacramento with 3 clinics as well. And we're also partnering with Kaiser Northern California. They are also working on a low-dose aspirin project. Next slide, please. All right, so implementation in terms of hospital and clinic outreach. So we have surveys, we have patient and provider surveys, and they are used to identify the barriers and facilitators to aspirin uptake, including things like patient education, access, and prescribing practices. They are in English and in Spanish. And here we can see the patient flyer with a QR code provided, and it only takes about 10 minutes, and they are provided with an incentive. Next. And then in terms of quality improvement, collaborative meetings, these meetings happen the last Friday of each month. And we have the hospital leads on here. We have clinic champions at each of the clinic sites. We also have some folks from the community-based organizations that we are partnering with. And we are lucky enough to have some of the patients from the Patient Advisory Committee be on board here as well. And just to mention, sometimes they share their stories on these meetings. So really cool, as I mentioned before, to uplift and empower these patients and really hear them. And then lastly, data regarding LDA is gathered in the hospital during the med reconciliation process. We are not gathering data from the clinics. And so there's no extra work to get this information into the MDC. And soon after I finish, we'll have Emily discuss the LDA data that is being collected. Next slide. Thank you. So we have some patient education materials that have been mentioned earlier on in the presentation. They are in English and Spanish, and as we scale up, we will provide them in more languages. We continue to identify and or fine tune the community messaging and outreach materials to educate women and birthing people about the role of low-dose aspirin during pregnancy. So for our patient education materials, we have an information sheet, a poster, and a patient risk assessment scorecard, which will be on the next slide for you all to see. Other outreach opportunities include videos, which Dr. Williams mentioned. We have been producing educational videos really showing the different provider and patient interaction scenarios, including discussions on maternal health disparities and how to really best model the conversations. One of the videos that we've done at our pilot hospital site is actually being used for educational purposes in grand rounds and in clinic and hospital settings. And then lastly, for the patient education, the patient advisory committee, that is patients with lived experiences who have delivered at or near the pilot hospitals that we're working with. They have met with the pilot hospital leads and they actually collaborate, and this really enhances the importance of patient and community voices. And currently we have about 11 folks on that committee. And just to note, they have had their eyes and thoughts and insights into producing these materials that we see here. Here on the left, we see the poster, and on the right is our information sheet. Also, you could see here that we have QR codes on the education materials, which takes folks to the March of Dimes website to learn more about the importance of low-dose aspirin. Next slide, please. And then here's the scorecard that we created. The original preeclampsia risk screening tool was created in collaboration between the task force, ACOG, and SMIFM. And so we also had our patients look at this because we wanted things that resonated with patients. Next slide, please. Oh, and this is also in Epic. Some hospitals have put that scorecard in Epic. So this is just showing some pictures. Melinda and I have gone out to the clinics and the hospital sites to meet with the clinicians that we're working with. And as you can see here, we have the poster that's actually posted in English and Spanish where patients are getting their blood pressure checked. We even have some of the posters in elevators at some of the hospitals that we're working with, which is really, really important because, you know, we don't just want to educate birthing people, right? We want to educate fathers. We want to educate cousins and aunts and uncles. So really cool to kind of have that where everybody could see. Next slide, please. All right, so for cohort 2, since we're kind of wrapping up our first kind of pilot group, what we'll do is we'll send out invitation letters to invite select hospitals to participate in the expanded LDA project beginning of next year. We will be recruiting, we looked at the data and we'll be recruiting a risk stratified by preeclampsia and preterm birth rates, high volume delivery sample of hospitals and affiliated clinics across California. We're still going to stay in California. We will continue to shape clinic to clinic QI planning and implementation. And lastly, we'll continue to have these collaborative meetings, including patients and provider tools, along with community engagement, the patients on the advisory committee, and much more. And now I'd like to turn it over to Emily.
Great, thank you, Lindsay. So I am the senior content expert for the Maternal Data Center. I will go ahead and share my screen so I can dive on in here. Let me know if you cannot see it. Hopefully you can. So I wanted to talk a little bit about the tools to support the Low-Dose Aspirin initiative that we have built into CMQCC's Maternal Data Center. So if you are not familiar, the Maternal Data Center is a confidential tool designed to support hospitals in their quality improvement efforts. So we have measures in the Maternal Data Center that measure hemorrhage and hypertension and sepsis and cesarean birth rates and newborn complications, a whole range of tools to support all of the work that you do within the hospital setting. almost every hospital in California that has a maternity service line does participate in the maternal data center. So if you are wondering, does my hospital participate in the MDC? The answer is likely yes. But in partnership with the Low-Dose Aspirin Initiative, we built in some tools specific to this project to help hospitals figure out where their opportunities for improvement are and the impact of the low-dose aspirin usage. So all of these tools are actually available for all maternal data center users at this point. We turned them on late last week. And so we've built in 5 new tools into the MDC to support your work. So one is a measure where we measure low-dose aspirin usage among those at risk for preeclampsia. This does require a little bit of data collection on your part, which I'll go into in just a moment. We can also track preeclampsia among those at risk for preeclampsia. So we look at those who are identified as at risk and therefore would have potentially benefited from low-dose aspirin, and did they end up with a preeclampsia diagnosis or not. We also created a distinct preeclampsia rate. For those of you familiar with the Maternal Data Center, we had an overall hypertension rate, and we would break it out into gestational, chronic, preeclampsia without severe features, and then preeclampsia with severe features and eclampsia. We split those 2 categories out and now have a combined overall preeclampsia rate. And then we also are able to look at preterm birth among those at risk for preeclampsia and the preterm preeclampsia rate, right? All of these are designed to help you evaluate what is going on with your patient population, what is the impact of low-dose aspirin usage in our population that is at risk, and whether our intervention is working or not, and where those specific opportunities for improvement may lie. What's nice about tracking these in the Maternal Data Center is that you can stratify any and all of these measures by race and ethnicity, by payer, by the delivery method, by the gestational age. You can track it by the prenatal care group. So if you tell the Maternal Data Center where that patient received care, we're going to be able to tell you the rate for this, the rate of LDA usage at this prenatal care site was X, or the rate of preeclampsia among those at risk for preeclampsia who received prenatal care at this group is Y. So there's lots of different ways to cut and play with your data in the Maternal Data Center. We really designed it to be a one-stop shop for all of your data needs, both within the initiative and outside. So to track these in the Maternal Data Center, as you log in, and this is our fake hospital with fake data, you would click on the data entry status button. This will take you to the data entry status screen, which will show you where to upload just your routine data files, as well as the rows where chart review may be necessary. So many of you may see this LDA usage row now. You would click on action needed for the month in question for which you wanted to submit data. So for example, if I want to submit data for July, I would click into action needed here. If you don't see this row, you will want to click on this select measures button to see the list of measures that you can add to your display. What we've done is we've actually turned it on for all hospitals under this select measures option. If you're part of the LDA initiative already, you will already have this row on your data entry status screen. But if you are a hospital who is maybe going to join cohort 2, or you know that you all want to start working on low-dose aspirin, but you want to see where you are, you want to get a baseline, go under select measures and you can add the LDA usage row to your data entry status screen. On the chart review screen, then the Maternal Data Center will actually filter down your patients so you just see those that had risk factors for preeclampsia. So that list that showed the high risk factors and the moderate risk factors, we've built that into the Maternal Data Center. And so we will filter it down to just those that are theoretically at risk for preeclampsia. And then you will be able to click edit and submit some data on that patient. So let's click edit here. We'll go to the next one. So the first little box that pops up, we ask 2 questions. did the patient take aspirin during their pregnancy as a yes, no, and where do they receive prenatal care? What's in this dropdown will reflect the prenatal care groups that you have identified in the maternal data center. This does take a little bit of time to set up, but we're happy to walk you through it. But you will be able to see all of your clinics or all of your sites listed in this dropdown after you've set that up initially. So if you say, yes, that my patient did take aspirin during their pregnancy, all of these additional questions will pop up. So we'll ask, what dosage of aspirin did they take during their pregnancy? You can choose between 81 milligrams, 100 milligrams, or 162 milligrams. We've added the 100 milligram option because our understanding is that that is sometimes the formulation that patients receive in Mexico. And so we want to make sure that we're able to capture that. And then we ask, when did they start taking aspirin and when did they stop taking aspirin? You can either put in the exact date or the week's gestation. If you put in the date, we will calculate the week's gestation for you. And then again, that question of where do they receive prenatal care? You can also use the comment section, which shows up whether the patient took aspirin or not, to add in extra information about the patient. So say, for example, we wanted to put in that they started aspirin once they've transferred care to the McCormick practice, right? This is my fake practice for my demo hospital. But you also may want to put in there that there was no documentation of education on low-dose aspirin for this patient, right? That is an opportunity for improvement. Or maybe it was recommended and the patient refused and they didn't feel comfortable taking it. That is also an opportunity for improvement for us to figure out, okay, was it something in our education? Was there information that we didn't provide? It's hard to know what those opportunities for improvement are until we actually go through and look at our data and identify those gaps. While you can do this by hand, you can also just create a spreadsheet of this information and upload it to the maternal data center. So if you are collecting all of this information through your medication reconciliation process, which is what we recommend, you can create a spreadsheet and upload it and save you a lot of time. This is then an example of what the trend line would look like. So this would show you low-dose aspirin usage among those at risk for preeclampsia. You can drill down to the patient level. So if you click into that rate below the graph or on a point on the graph, you're going to be able to see everyone who was at risk but didn't receive it. Again, a great way to identify those opportunities for improvement. You can track interventions on a run chart. So you can actually click on a chart and add in saying, we joined the LDA initiative on this day and we rolled out patient education materials on this day. And then we'll be able to show you what the average rate was before you did that intervention and then after. And then again, you can compare and stratify your rates in a bunch of different ways to identify those specific opportunities for improvement. Another interesting tool here is you can also overlay metrics in the maternal data center. Sometimes this is your best way to identify if there potentially is a relationship between your intervention and the outcomes, or to see if that intervention is working, right? So you can see in this example, again, fake hospital with fake data, we've overlaid the LDA usage among those at risk for preeclampsia compared to the preterm birth rate among those at risk for preeclampsia. So we can see when the LDA usage went down, we actually saw a rise in the rate of preterm birth. So lots of different ways to utilize your data in the maternal data center. I know this is a very brief primer on what's available. We are happy to walk you through this process. So if you are interested in tracking this in the maternal data center, we have user guides to help you do so, but we're also happy to walk through this with you. So you can reach out to us at datacenter@cmqcc.org, and we'd be happy to meet with you and figure out how to support your data needs throughout this process. With that, I'm going to pass it back to my colleagues to close us out, and then we can answer any questions.
Thanks, Emily. So we are going to continue our webinar series. And so our next webinar will be on January 16th. It is entitled Preventing Preterm Birth and Preeclampsia, How Can Pharmacists Help? We know that pharmacists play a crucial role in this work. So please make sure you register for this webinar. You can see that QR code that you can scan, or there's the website as well. Next slide, please. Oh, thanks. And then lastly, please follow us on our social media channels for any upcoming events, our webinars. Also, I'd like to kind of give a shout out to Laura Headley. She is an amazing science writer for the Division of Neonatal and Developmental Medicine at Stanford. And she actually interviewed some pretty phenomenal people, Dr. Amanda Williams, who is with us here, and then Dr. Audra Meadows, who is an OBGYN at UC San Diego, one of the pilot sites we're working with, about what we talked about today. So about discussing risk respectfully, how can we talk about preeclampsia and LDA with patients. So please check that article out. It is on our website, and you can also access our patient education materials as well. So thank you so much. I think we have a little bit of time for some questions. Thank you for attending.
There are a couple questions in the Q&A also, if our panelists want to look at those.
Thank you. Yes, we've been answering those, and you can see any answered questions on that Q&A function. I want to give you a chance. I know, Dr. Williams, you did click that you would answer one of the questions live. I want to give you a chance if you had any other comments on those Q&A.
I think I'm going to just answer this last one. You know, in terms of presentations, we are happy to come out to or do Zooms, depending on your location, to CMQCC hospitals and practices in order to help support this work going on at your site. So just let us know and consider joining the second cohort. Those invitation letters are going to be going out shortly.
Wonderful. And then we also put links in the chat regarding that upcoming webinar to register, regarding the new article that's out on our website and the LDA page on the CMQCC website. So we also had a lot of questions about contact hours. I just want to address that. We again will send out a webinar evaluation tomorrow. Please fill that out, and then we will follow up via email if there's any other questions through our contact MCPOP account. So watch for that, or email them if you have any questions. And that is in the Q&A if you need that email address. So Dr. Williams, would you like to close us out?
Sure. I think that's it for us. Thank you so much for joining. Remember that the more different a patient is from you, the harder that you have to listen. And that if we can have these conversations respectfully around issues such as exposure to systemic racism, obesity, and really listen with our hearts and our minds, and that the patients know that we are doing this because we care about them and we want things to be different, I know that we can really make a dent in preeclampsia and in preterm birth across the state of California. So we will stop the webinar now, and thank you so much for joining us.
Thank you. Bye-bye.
Thank you all for attending.
Thank you.